Evening, and thank you for joining us tonight for Relationships and Intimacy. This webinar series is brought to you by Can Do Multiple Sclerosis, the National Multiple Sclerosis Society, and the Multiple Sclerosis Society of Canada. My name is Laura Allen. I am the Programs Manager at Can Do MS, and I will be your moderator this evening. Can Do MS delivers health and wellness education programs to help families with MS thrive. If you visit the Can Do MS website, cando-ms.org, you can learn more about Can Do MS's online and nationwide in-person programs. Now, just to clarify, right now we're not doing in-person programs due to COVID, but we have pivoted those programs to a digital format. So I encourage you to check out our website and look at our virtual offerings. You'll see that our one-day Jumpstart program is now being offered virtually, and I encourage you to sign up and attend some or a lot of those upcoming programs. The mission of the National MS Society is to help people affected by MS live their best lives as they stop MS in its tracks, restore what has been lost, and end MS forever. You can explore other society programs, services, resources, and connection opportunities at nationalmssociety.org. We will save about 20 minutes at the end of this webinar for questions and answers. So if you do have a question during the presentation, you can type it in using the questions chat box, which is found in your control panel. The presentation is being recorded and will be archived on the Can Do MS website. And in addition, you can download a copy of tonight's presentation as well as additional resources, and that access will be found in your control panel. You can also access these resources in the follow-up email that will be sent out by the end of the day tomorrow. Our speakers this evening are Megan Beyer and Kathy Healy. Megan Beyer is a rehabilitation psychologist and clinic researcher specializing in multiple sclerosis at the Johns Hopkins University School of Medicine. Her research and clinical focus is on cognitive and emotional symptoms common in MS. Hello, Megan.
Hello.
Thanks for joining us tonight. In addition, tonight we have Kathy Healy. Kathy is a nurse practitioner and has a PhD in neuroscience. She has been working in the field of MS since 1998, and she is an assistant professor at the University of Nebraska Medical Center. Hello, Kathy.
Hello.
Thanks for joining us this evening. And now I'm going to turn the meeting over to Megan.
Thanks, Laura. So I wanted to start by talking about what our learning objectives are. We want this program to help you understand the ways in which MS can impact your intimacy and the roles that might impact intimacy. We want this webinar to focus on learning strategies for discussing and problem-solving changes in your intimacy. And we also want you to have strategies for maintaining a balanced and satisfying partnership. We also wanted to lay down some expectations for the presentation. We're going to go over a lot of different factors that could impact your sexual intimacy tonight. And some of those may fit you and some of them may not. So what we want you to do is kind of listen throughout this entire presentation, write down anything that you think might impact you or might be relevant to you, and then start to explore those with your partner, with your family, and with your healthcare providers. There may be more than one thing that's contributing to difficulties with sexual functioning, so you want to explore all the different things that could possibly impact you, and those barriers or those things that could impact your sexual functioning can change over time. So this might be something that you have to revisit as time progresses. So what do we mean by intimacy? We're not just talking about sex, although that's a big portion of tonight's talk. We define intimacy in a number of different ways. We think that it is about warmth, connection, closeness, and trust. It's about deeply knowing another person and feeling deeply known. And it can, but does not always involve the following things: communication, spending time together, hand-holding, cuddling, sexual touching, or intercourse. We want to know who's in the audience tonight so we can speak to you and your specific needs. So in this next polling question, tell us a little bit about yourself. Okay, so it looks like the majority of the people in the audience are females over the age of 40 and males over the age of 40, very few males under 40, and a few females who are under the age of 40. Next, we want to know if you're a person that's a support partner or if you're an individual living with multiple sclerosis. And because severity of illness can impact your sexual functioning, we also want to know about a little bit about your type of MS. Okay. So it looks like we're almost about even in terms of people with MS who use assistive devices or who do not. And only about 3% of people are support partners, although I imagine there's probably some people who are watching this together. Okay, I'm going to turn it over to Kathy.
So thank you, Megan. So intimacy and sex is an important part of our overall health. And research has highlighted several possible benefits besides procreation that come with intimacy and or sexual intercourse. Sexually active people take fewer sick days, suggesting a better immunity. Researchers also found that people who had frequent sex, which they defined as 1 or 2 times a week, had more IgA, which is an immunoglobulin in their system, than others. IgA is an antibody that lives in mucosal tissues, glands, nose, and vaginal tissues, and really heads off infections. Preserving health of the heart in some people and also reducing blood pressure have been found to be some benefits of frequent sexual activity. Sex can also improve mood, relationships, and mental well-being. And males who ejaculate more frequently have a lower risk of prostate cancer. Intimacy and sex can serve as natural ways to relieve stress. A 2019 study looked at the effect that intimacy had with a partner on cortisol levels, and cortisol is a steroid that circulates in our body in response to stress. And the researchers found that expressions of intimacy, whether sexual or not, help bring cortisol levels in both males and females back into normal range. Sex triggers the release of oxytocin, dopamine, and endorphins and other feel-good hormones, which may be responsible for reducing stress and also reducing pain. So orgasm has been found also to block pain. So researchers also found that vaginal stimulation alone without orgasm can block chronic back pain and leg pain. So before you reach for your aspirin, you may try an orgasm. The National Sleep Foundation suggests that sexual activity has hormonal benefits for sleep and produces a chemical called prolactin, which induces feelings of satisfaction and relaxation. There's also some evidence that blue zones, those areas around the world where people live, their life expectancy is longer, report higher sexual frequency and live longer, although it may be that those healthier people just have sex more often also.
So why are we talking about sex and intimacy with the MS group here with Can Do MS? We know approximately 80% of people with multiple sclerosis experience sexual problems at some point in their life. But they're not the only people. Individuals with MS are not the only individuals who experience sexual problems. Actually, it's quite common in the general population and people without medical conditions. So about 35 to 40% of the general population report at least occasional problems with sexual functioning. So This means that whether you're a person with MS or a support partner, it's your right to ask questions as a regular part of your health care.
So intimacy and sexual response is complicated. Many of us remain uncomfortable with even talking about sex. And a recent survey showed that almost 70% of adults would like more education on or about sex. So here's a little anatomy and physiology as well as sexual phases. So sexual arousal begins in the central nervous system, and the brain sends messages to sexual organs along the nerve pathways in the spinal cord. MS lesions in the spinal cord or brain can change nerve pathways and create a disconnect between the brain and physical sexual functioning. It can directly or indirectly cause sexual dysfunction. So this is, I'm going to try to explain the phases of sexual functioning. So the first phase, and that starts in the brain, and that's called the libido or desire. And I'm not sure if you can see my, yeah, now you can see it. So those are like desires and feelings that come from our brain, and those can be mediated by a hormone. And the sexual hormone we typically think about, or the main one, is testosterone, and that is present in both males and females. And that certainly does have something to do with libido or desire. However, a lot of other things can influence sexual desire, including psychosocial and cultural factors, body image, performance anxiety, mood changes, anxiety, and even quality of relationships. Megan will talk quite a bit more about those sorts of things later on. So once that thought is processed and there's desire for sex, just thinking about sex or foreplay can start a stage called the excitement stage. And what that is basically nerve impulses running up and down the spinal cord and they innervate the sexual organs here through peripheral nerves, which have contact with vessels. And so vascular health is a big deal when we look at sexual response. So again, the impulses go up and down the spinal cord, and we know with MS there can be lesions here. There's more lesions typically in MS that sit towards the posterior part of the spinal cord, generally responsible for sensation. So once this excitement phase is at its peak, what happens is that due to the innervation of the central nervous system to the vessels, then organs engorge. So vessels dilate and our sexual organs become congested. And that causes erection in a male. And you can see this is the penis has just lots and lots of vessels in it, and that engorges with blood. Pretty much the same way, males and females are not too much unalike, but the same thing happens in the female, where the vulvar area engorges as well as the clitoris. And you probably all know that the nerve fibers for sexual response are throughout our body, and that's why body mapping is good. But the majority of sexual nerve endings, of course, in the male is in the glans penis, and in the female it is the clitoris. A lot of people a long time ago, they thought that there was a spot in the vaginal area, but that is not so much true, although there may be some, but generally it's the clitoris where most of those nerve fibers are in females. So after that excitement stage, then there is a plateau phase. During this excitement and plateau phase, not only do the organs congest, but the female vaginal area becomes moist and lubricates, which is important for sexual intercourse. And then of course, there is the orgasmic phase, and that may or may not happen. People don't always have orgasms. And when that happens, the male ejaculates, and the female, as well as the male, has muscular contractions in their pelvic floor muscles, as well as all over their body. Note to self that usually orgasms do not occur at the same time. And that's kind of something that we see in the movies, but that usually doesn't happen. After orgasm, then there is a last phase, which is resolution. And that's where a lot of those hormones are released in the brain, and it causes, whether or not there's orgasm or not, that and or intimacy causes those chemicals to be released in the brain, causing relaxation and in many cases promoting sleep. I just want to note here too that not only is the vascular system important for the sexual response, but look at the structures and the relationships in the pelvis. So here's the penis, and here's the bladder, and here's the colon. And the same way over here with the female, here's the vagina, here's the colon, here's the bladder. So if the colon is full of feces or stool, or the bladder is overly filled, that can absolutely interfere with the sexual response. In males, you can see over here is a prostate gland. Enlargement of the prostate gland can also inhibit erections and other parts of sexual response. How frequently in the past 12 months have you experienced intimacy challenges? Never. A little, that's less than 25%. Occasionally, 26 to 50% of the time. Frequently, 51 to 75% of the time. Or consistently, 76 to 100% of the time you've experienced challenges. Okay, so it looks like the majority of people have frequent or consistently have challenges with sexual response.
Okay, so you'll see from our talk that researchers divide sexual difficulties into 3 different areas: primary symptoms, secondary symptoms, and tertiary symptoms. Where normally we would start with primary, which would be things like an MS lesion, like Kathy referred to earlier in the spinal cord, impacting sexual response. We're actually going to start at the bottom of the pyramid here with tertiary symptoms, which are things like psychosocial issues, things like communication. One reason we're starting here is because we think it's really important for all of the different areas, primary, secondary, and tertiary, for us to consider communication and psychosocial factors, because they have such a huge impact throughout. So over the next couple slides, I'm going to talk about how do you start to talk with your medical team about sexual problems that you're experiencing. So first of all, we think it's incredibly important for you to talk to your medical team about sexual problems. It occurs just as frequently as some of the most common MS symptoms, but doesn't get talked about very often. So why is that? Why hasn't your medical team asked you about sex or sexual problems? Well, there was a study that was done in 2006 by a researcher named Fred Foley, and he went to MS doctors and medical staff and asked them, why aren't you talking to your patients about sex? So one of the #1 reasons was that they felt like they had limited time, and that there were other things that took precedence. Some felt like it was outside of their role, or maybe they didn't have enough education. They weren't sure how to address these symptoms. They felt like their patients were uncomfortable with this topic, when, you know, I would hypothesize that maybe sometimes that was the provider also feeling uncomfortable about these discussions. And again, about 6 to 7% of people felt like they didn't have the training or comfort to talk about these topics. There were other priorities. They didn't feel like medical coverage handled this. They felt like it was too intrusive. But what they found was that generally, when they talked to individuals with MS, they wanted their doctor to talk to them about sexual functioning. So we bring this up because it may be on you, unfortunately, it may be on you to bring some of these topics up to your physician. And quite frankly, after hearing this talk, you may know more than some of your providers about sexual problems that come along with MS. So it's important for you to kind of take that first step. So we wanted to know, who do you feel comfortable talking to about sexual problems? Do you feel comfortable talking to your partner, to your healthcare team, one or the other, or both? Good. Well, I'm glad to see that, just a little under 50% people feel comfortable talking to both their partner and their healthcare provider. That's a little bit higher than expected based on some of the data, so that's really good. Some people said their partner, some just their healthcare provider. So who should you talk to about these problems? Well, you can talk to anyone in your medical care team. Your primary care doctor is a good place to start, a nurse practitioner or a physician's assistant, your MS neurologist, a nurse in the office or case manager. Counselors and psychologists often really dive into these conversations pretty deeply, and so they're a good place to start. A urologist, if you're seeing them. I also very highly recommend a physical therapist or a physiatrist, which is a rehabilitation physician. Specifically, there are physical therapists called pelvic floor therapists who specialize in issues like this and really know a lot of information. So there are plenty of people that you can talk to, and even specialists that you can go see if your primary care doctor or your MS neurologist maybe doesn't have all the answers that you're looking for.
So it's important to investigate the problem too, and not all sexual dysfunction is related to multiple sclerosis. So here's some other things that can cause sexual dysfunction. So you really have to investigate it, describe it to your provider so that they can either work with you regarding that symptom or refer you on. So even though it might be a little bit embarrassing, I mean, let us know exactly what the issue is. Is it with the erection? Is it with an orgasm? Is it? So that detailed information is important. That also gives us some idea of what the etiology is. So vascular issues, like we talked about in the anatomy, can cause sexual dysfunction, hormonal disorders. Tobacco use, depression definitely can influence libido and desire. Prostate enlargement, changes in the pelvic structure like fibroids, endometriosis, things like that. And those are just a few things. Medication and other substances can also contribute to sexual dysfunction. For instance, blood pressure medications. And a lot of people are on blood pressure medications. And so if you talk to your primary care physician, just like explore, gosh, could it be the blood pressure med? Did my sexual dysfunction get worse when I started it? So things like that. Antidepressants are also a big contributor to sexual dysfunction. And most of, at least the individuals I take care of are on antidepressants. So some are worse than others as far as affecting sexual response. The SSRIs and the SNRIs can have an effect on erection as well as desire and orgasm. There are some tricks that you can do with antidepressants, but talk to your provider about it. Sometimes, depending on the length of time those stay in your system, sometimes you can hold the antidepressant that day. There's also antidepressants that have less effect on the sexual response, like things like bupropion or Wellbutrin. Opioids or narcotics can definitely affect the sexual activity. Antihistamines. Alcohol is a big one. It does diminish performance and delay orgasm and ejaculation. That's excessive alcohol. And anti-epileptics and some anti-reflux drugs can also influence sexual dysfunction. So the primary symptoms, again, Megan talked about this and I talked about it before. These are sexual issues caused by an actual lesion of multiple sclerosis in the brain and the spinal cord. And these are called the primary etiology of symptoms. So primary sexual effects can cause a lot of different things. Decreased libido, altered sensation, difficulty in maintaining erection, lubrication, muscle tone, and difficulty in ejaculation, as well as problems with orgasm. It's important to know that last slide with men, the major issue tends to be when they come into the clinic, as far as research goes, they report more sexual or more problems with erectile dysfunction. And orgasm, and as for women, it's more issues with sensation and decreased libido. So libido or desire, that again is that that thought we get or the urge we get to have sex. Sometimes you have to do things to get there. So this person with MS said, having my partner massage me gently beforehand helps me get in the mood. Using a scented candle or oil. A lot of things can be used to increase libido or desire. Really important things are make time for foreplay. Sex shouldn't really be, intimacy in sex should not really be rushed. Let's listen to relaxing music. Megan talked about the importance of communication, and that's really important too during sex. So that if a partner is hitting the right spot, if you will, even though it could be embarrassing, you might have something, yep, that's it, or some sort of cue that you're being pleased. So also try body mapping. That's always, it's interesting how many people can have different areas that can elicit pleasure. So, and individuals are different. So there are more details about body mapping at the end of this presentation in our reference section. So lack of sensation, and this usually is the most, this primary thing that women report to us in clinic. And this woman with MS says, in order to reach an orgasm, I have to use a vibrator. It was actually a partner who suggested it. I was very embarrassed at first, but it's brought an added dimension and creativity to sex. I would urge anyone who is having difficulty in reaching orgasm to invest in a vibrator. And if any of you watch the Netflix series Frankie and Grace, I think they have normalized vibrators, especially for older women. Who also need more stimulation. What's interesting too is that men can benefit from vibrators also, and that stimulation to the penis with a vibration with a vibrator may enhance erection. There's other things to do for lack of sensation, different sort of sexual positions. Again, communication is with your partner is very important. Those sorts of cues or direct directions for stimulation. So I think Megan was going to do this one.
Sure. So I'm talking about this one largely because I went to one of our pelvic floor therapists who who specializes in MS at our hospital, and I said, I'm doing this presentation on sexual functioning, and do you have any suggestions for me, anything that we should talk about? And she sent me a massive amount of information about lubrication for women, and it was more information than I ever knew. So I think that this is a really important topic, or there's a lot of different treatments and different things that you can try, but one of the primary issues that happens with women is lack of lubrication. So if you're thinking about adding a lubrication to try and help with this, there's a few things to keep in mind. Number one, are you trying to get pregnant or not? Because certain lubes can have an impact on your ability to become pregnant. If you have lack of sensation, there's certain lubrications that work better that can actually help enhance sensation. And there are certain lubrications that can actually help decrease genital pain or help with pain. And there are some that can actually break down condoms. So you want to make sure you're using ones that are, if you are using a condom for contraception or for STI protection, that you're not using a lubrication that can break down those condoms. There's a lot more information, again, in some of the resources that we put at the end of this presentation that you'll be able to access when Laura sends the slides.
So erectile dysfunction, again, this is the most common symptom reported by men. And again, just to reiterate, some additional stimulation may be helpful, but the mainstay anymore is drugs called phosphodiesterase inhibitors. And these drugs include things like Viagra, and similar drugs. There are several out, Levitra and Cialis, but usually the drug is taken about 30 to 60 minutes before sex. And what it does is it acts upon the vessels and allows the vessels in the penis to engorge and produce erection. And so a study done specifically in MS showed about 89% of men had sexual improvement of erections versus 24% of placebo. There can be side effects to these drugs, and headache, flushing, sometimes like an upset stomach. It's contraindicated in men who are taking nitrates and or who have had a heart attack or stroke within the past 6 months. These drugs are typically given by either primary care, neurology, or urology. But I would suggest working with a physician who you can talk to versus purchasing over internet and with providers you really don't know. Another strategy for erectile dysfunction is a vacuum device, and it's non-invasive, which is good. And with this method, a plastic tube is fitted over a flaccid penis, and then a pump creates a vacuum that pulls the blood into the penis and subsequently produces an erection. Then a latex constriction band is slipped onto the base of the tube and onto the base of the penis, and the band maintains the engorgement of the penis for sexual activities, although it cannot be used for more than 30 minutes. Another technique for erections are injections, and these are prostaglandins that are injected into the penis, and it just sounds difficult to do. However, it's injected about 30 minutes before intercourse, and a good proportion of men do get good results from this. The problem with these injections is it could cause priapism, which is an erection that is present and doesn't go away, and that's basically an emergency. and men do need to go to the emergency room if that happens. It has been found to maybe cause seizures and some fibrosis, especially if it's injected frequently. The last resort, and this is invasive, is penile prosthesis, and those can be different types. There's semi-rigid malleable prosthesis that can be bent into different shapes. There's also one that has a pump that can inflate the prosthesis. So secondary symptoms of MS that can interfere with sexual response would be things like symptoms, those sorts of things that can interfere and not directly cause sexual dysfunction. And so common ones experienced by people with MS are fatigue, spasticity, bowel and bladder issues, sensory changes, and also pain. It can be experienced by people with MS. So for bladder issues, bladder dysfunction during sex is common, and many people will become incontinent and be embarrassed. But, you know, I always tell people to remember sex is wet. Sex is a messy sort of thing, and there can be things that you can do prior to sex to maybe minimize that issue. So going to the bathroom, emptying your bladder, or cathing before sexual activities is important. You can avoid fluids several hours prior to sex, but you don't want to, you know, be dehydrated and avoid fluids for longer periods of time. Most women will put a pad on the bed, or men or women pad on the bed and some sort of nice cover. Males can use condoms to prevent leakage of urine. Also, Kegel exercises are helpful in strengthening the pelvic floor and potentially improving incontinence. Urinary tract infections are common in the general population as well as women with MS. So it's really important that that after sexual activities that you go to the bathroom. We tell people to pee after sex. I know it's not real romantic, but it is important. Catheters, if you have catheters, indwelling catheters, yes, you can. And we didn't have a whole lot of information or slides on this. However, there is another website and a site that you can go to if you have a catheter. But absolutely, you can have sex with catheters. It's probably easier if it's not a urethral catheter. It's probably easier to have sex if you have a suprapubic catheter. And you know, if that's the case, definitely talk to your urologist. And bowel issues can be a problem too. So remember the anatomy. So a full colon can predispose people to incontinence of stool, also to pain and just discomfort when having sexual intercourse or sex. So it's important. I tell all my patients it's so important to maintain a good, healthy bowel program. And depending on your situation, this may include something as minimal as, you know, 5 prunes the night before you plan to have a bowel movement, or all the way up to suppositories and enemas. But it's really important so that you have a consistent bowel program, your bowel movements are predictable, and then that doesn't get in the way of sex as much. So spasticity, that tends to be a very big problem too. Here's a quote from someone with MS. I find laying on my back, clutching a knee with each hand towards my shoulders work. My knees have to be bent right up to break spasticity. And this position also means I can have lazy sex when I'm knackered. So that's it. That's good. This person has a good sense of humor, and that's what we need too. So with spasticity, it's really important to stretch. So stretching, you probably all know this from your physical therapist, but with a good stretch, you want to hold that stretch for 30 seconds and do 3 repetitions. Anti-spasticity medications about a half an hour before intimacy or sex can also be good. And positioning, if there's a position that causes spasticity, avoid it. The other thing, as you all know, that causes spasticity is pain. So if there's any pain with intimacy, sexual intercourse, so you have to modify that. Full bladder will cause more spasticity, and a full colon will also trigger spasticity. So fatigue, most common symptom reported by people with MS. So what I usually counsel people to do is have sex at a time where you have the most energy. For a lot of people, that's in the morning. Anti-fatigue meds are helpful. And you can talk to your provider about your fatigue. It's such a common symptom, and discussion is important. Change positions use positions that take less energy. Take a break when you start to tire. Quickies are good if there's a lot of fatigue, and really important is to stay cool. We know that even the increase of a half a degree of body temperature can cause fatigue and weakness in some people with multiple sclerosis. So putting on a fan, maybe ice collars, things like that. So I'm going to have Megan take it away.
Great. So the final part of our triangle here is the tertiary symptoms, and those are issues, sexual issues that are caused by emotional symptoms, changes in role, or psychosocial factors. So some of these things, just a few, not an exclusive, not an exhaustive list, are things like depression. I would add anxiety, just general stress to that list. Performance anxiety, if you're worried about how you'll perform in front of your partner or what your partner is thinking about your performance. Changes in your body image. So if you've gained a little bit of weight over time, or if you are starting to use an assistive device, many people start to talk to me about that those changes in their body gives them lower self-body image, and that can cause some discomfort or cause you to sort of withdraw from sex and your partner. So just like we said about communication being important for your medical team, it's essential for communication with your partner. This is again a quote from a person with MS. This person said, "It was worth the embarrassment of telling my partner what I really enjoy. Now he really knows what turns me on." There was one study that found that only 9% of couples are comfortable talking about sex. So I was glad to see earlier in our poll that so many people were comfortable talking about sex with both their partner and their medical providers. So because the problem is that when you don't talk about it, you tend to withdraw from intimacy even more, and then your sex life suffers more. So having sex and talking about sex can be a very vulnerable experience. And when you have reduced connection with your partner, reduced intimacy, or you don't feel safe with your partner, either emotionally or physically, that can cause you to pull back, try to protect yourself, and be less vulnerable. So why is communication so important? I wanted to highlight this one study that was done by Dr. John Gottman and Dr. Levinson. And this study was done in same-sex couples, but I think it can apply across the board. This was a 12-year study of gay and lesbian couples. And what they found was that their sexual unions were comparable in terms of satisfaction and quality, but there were a few differences. So gay men and lesbians tended to be much more direct in their communication. In terms of conflict management, there was less physiologic flooding. And what that means is that when somebody gets uncomfortable, they might start to feel overwhelmed and kind of have this flood of emotion come over you. You might freeze, you might react in anger, or sometimes you might just retreat with that kind of flooding. They this study found that they used a lot of humor when they were having conflict, which reduced that frequency of flooding. They were often good friends, and they talked much more directly about sex, and therefore had a more contented sexual relationship because they really understood what each other's needs were. In another study by John Gottman, he looked at people who who reported having a great sex life, and he wanted to look at what were the things that were different about this group who reported having a great sex life versus couples who reported lower sexual satisfaction. So some of the things that he talked about have really nothing to do with all of the factors that Kathy was talking about, but more factors that have to do with just feeling more connected to your partner in general. They said, "I love you" every day, and they meant it. They kissed each other passionately for no reason. I think he actually timed it to saying 6 seconds of a 6-second kiss can actually increase your feeling of connection with your partner. They would give each other romantic gifts. They would know what turns their partners on and off, so they would talk about the things that turned each other on and off erotically. They were physically affectionate even in public, so sometimes that's like holding hands or just touching the other person's shoulder, just being physically affectionate. They kept playing with each other and having fun, meaning they did things they enjoyed together. They cuddled. They made sex a priority, so it wasn't the last thing on the to-do list. It was actually a part of their everyday routine. They maybe even scheduled it. They considered their partner a good friend. They talked, again, this is the second one, they talked comfortably about their sex life. They had weekly dates, and they sometimes were able to take vacations, romantic vacations. What about those people who said that they felt like their sex life had declined? What did their life look like, and how was that different from the people who said that they had a great sex life? They spent very little time together during a typical week. They became either very job-centered or very child-centered. Their communication mostly centered around to-do lists rather than other kinds of things that brought them together and helped them connect. They made everything else a priority over and above their relationship. They tended to drift apart over time, maybe without even noticing, and they tended to live parallel lives. And they were unintentional about turning towards. And turning towards means if you're sitting on the couch and you're looking at your phone and your partner starts to talk to you, you put the phone down and you turn towards that person. So it's when the other person's kind of bidding for your affection, or they're looking for you to connect with them in some way. It doesn't even have to be a physical connection. You direct your attention towards that other person. So in this case, people were unintentional. They did not do that as frequently. So what if you are kind of in the place of wanting to talk more about sex with your partner, but you're in the group that doesn't feel super comfortable doing that? Here's a few tips, or even if you do feel comfortable, here's a few tips for talking about sex more openly. One thing is to prime the conversation, to sort of let your partner know that you want to have a conversation about this. So that might be something like, "I'd love to talk about how MS is impacting our sex life and how we can make things better for both of us. Can we talk about it later after the kids go to bed?" You want to give reassurance to the other person. A lot of times there's sensitivity around feeling like maybe you're not satisfying your partner, or even your partner without MS might feel like you're not as interested in them anymore. And so we want to provide reassurance to both people or to all partners. I frequently feel attracted to you, but the kids really sap my energy, or I'm feeling really fatigued lately. What if if I wasn't up for having sex, what if I told you each time I looked at you and felt attracted to you? So kind of giving reassurance to your partner, describing your experience, but also asking for your partner's experience. So listening and asking questions, and really trying to be non-defensive while listening. So some tips for being non-defensive is you might have a notebook out and take notes on what your partner is saying. so that you don't start to think of your response and shoot that out rather than hearing what your partner is saying. Some other ways to be non-defensive while listening is kind of to take some deep breaths. And as a kind of a therapist out there in the community, Brene Brown says, get really curious about what the other person is thinking and feeling and why they might be thinking that way. Make suggestions, but not complaints. So that's things like Kathy was referring to, maybe having a code word when something's going well during sex. I really love it when you X. Or I was thinking if we used a vibrator, that might help with my lack of sensation. Or I was thinking maybe we could put a towel down and that would make me feel less embarrassed when I have bladder issues. So come up with some ideas that you want to try and bring them up. And even if your partner is not open to those suggestions, again, try not to be defensive or keep yourself vulnerable, put yourself out there, and really try to hear what your partner is feeling and maybe if they have some alternate suggestions that you might be open to. So what about dating? We've talked about a lot about people who have partners, but there are plenty of people in the audience who maybe are not in a long-term committed relationship. So this person with MS said, I wait until the second date before I tell them I have MS. If I like someone enough to see them again, I reckon I should tell them. If I leave it longer, it feels like an elephant in the room. Somehow that seems to make it a bigger deal than it is for me. MS is just a small part of my life. And so this is just one person's take on this. There's lots of different takes on it. There's no right or wrong time to talk about having MS or having sexual difficulties with MS. You kind of have to feel out what's right for you. Maybe try things and see if it works out. And I would say that in the cognitive behavioral therapy world or the psychology world, there's something called fortune telling, where we tend to predict what we think is going to happen. And oftentimes, there was a study that was done that 90% of the time we're wrong about our predictions. And so we often can't predict what that person's reaction might be. We might get part of it right, but not the whole thing. And you might often be surprised by positive responses. But I also want to be realistic and say that you can't always prevent negative reactions. So what are some ways that you would be able to comfort yourself or grieve or have a friend that you could talk to or a family member if the conversation doesn't go the way that you hope it will? So I wanted to leave you with a few tools. John Gottman is a really famous researcher in the world of dating and sex and marriage. And he has an online quiz that you can give yourself. This has been validated in a number of studies about, kind of where you stand in terms of sex, but also general intimacy. So if you kind of want to give yourself a quiz and kind of see where you stand in some areas that you might be able to work on with your partner or with yourself individually, this is a good place to start. If you're not sure how to improve your communication, he also has a free app that gives 3 different categories, kind of mild questions to ask your partner or conversation starters, medium, and spicy. And so you can kind of work your way up to getting more comfortable talking about different topics around sex. And the next 2 slides here are resources that we've referred to throughout the conversation. So this Sex and MS guide, a guide for women, quite frankly, most of it is applicable to both men and women, and there's really detailed information about a lot of the kinds of topics that we talked about and different treatments that might be helpful. Sex, intimacy, and relationships is another large pamphlet or brochure that talks about this. There's a video here about from an individual with MS who's experiencing sexual dysfunction and what that's like for him and different ways that he addresses it. There's also a video here that Kathy brought to our attention that is an individual with a spinal cord injury and his experience with sex and dating that next one is different tips and strategies and ways to have sex if you have a catheter, as well as a few other resources here that maybe I'll have Kathy talk about a little bit because she added those.
And so the American Association of Sex Educators and Counselors, and this is a site where you can actually see if there is someone in your area that is a sex educator or counselor. And these are therapists that are certified and licensed. And then O School is just out there. O is for orgasm. And so it has some, it's a good site. It's a reasonable site. I know that it's hard to know what site sometimes to go to just because some of them are not legitimate. But these appear to be some pretty good, helpful resources. And so we'll end with some takeaways. You know, investigate the issue that you're having with sexual activity or your challenge. Really define it, determine the problem areas, talk about it, explore and learn. Knowledge is power. I think we all firmly believe that. Also have a sense of humor and then teach. Like Megan said in the beginning, you may actually, after this presentation, may know more than some of your providers, but teach people if something works for you, maybe teach other people that have the same issues. And I think that is it. Thank you so much.
Terrific. Thank you so much, Kathy and Megan. I really appreciate all the information that you, let me put my webcam back on, all the information that you provided tonight. And I do want to note that throughout this presentation, you referenced a lot of resources, which we saw at the end of the webinar. You can download those this evening in your control panel. There are 3 handouts. One is the PowerPoint, one is the resources, and one is a library article that Kathy and Megan put together on this topic. So those are downloadable right now, and they will be sent in the follow-up email that you get after the webinar. So that being said, let's continue talking about resources. Many of our participants do find themselves disabled, and they asked if there's a resource that you can point to that would help with sexual positions when your legs do not work. Kathy, can you do you have any ideas for that?
Well, I don't know of a specific resource for that. But you know, it's so different between different people with multiple sclerosis, their degree of spasticity, where the spasticity is. I would talk with, you know, a neurologist or physical therapist. There is a whole lot of things that can be done for spasticity, including, you know, orals, injectables, pumps. But, you know, to start out with, positioning where there's not as much pain and really trying to effectively stretch the area of spasticity prior to any sort of sexual activity, and then doing some of those things that we talked about, like making sure that your bladder's not full or there's no pain, things like that.
So
I don't know, Megan, are you?
The first resource that's on that the list that we showed, that was the MS and women resource, does have some positioning information in there. And I would imagine probably that resource that you shared, Kathy, of the individual with a spinal cord injury, that website likely has some other resources as well.
Great, thanks, Megan. So many partnerships find themselves as a person with MS and a caregiver. And this person writes that her partner has quit seeing her as a sexual being. I think that that you might see that sometimes, or have seen that before, Megan. Can you give any sort of suggestions or advice to this person?
Yeah, absolutely. So I think this is really common, especially if partners start taking on a bigger caregiving role. And the first step I would say is communication, but the other, so talking about that, talking about the sense that you get that your partner isn't seeing you as a sexual being anymore. The other thing is potentially even separating the caregiving role from your role as a partner, as a spouse, with the other individual. So can you set aside time where the things that you're doing and the conversations that you're having are specifically around your partnership and less about what needs you might have, or maybe even having somebody else start taking care of some of those needs as well, so that you can have a stronger relationship that it may not entirely give up that caregiving role, but that maybe it's separated and it has its time and place. If you have difficulty having those conversations or kind of don't know where to start, a lot of times working with a health psychologist or a psychologist that specializes in rehabilitation, which is individuals living with chronic medical conditions or disabilities, those types of psychologists have these kinds of conversations with partners all the time. So they would be a good place to start.
Great. One of our participants writes that, I'm not sure, it's a she, is 70 years old and has no libido. Can you give her any suggestions?
Well, with libido, it's been reported in women who don't have the desire to go ahead and start the activity, and sometimes the desire follows. That's one tip. Yep. There's also some, at the age of 70, there's some thought about hormone replacement, and I don't think we talked about estrogen cream, and that is helpful. That is not only helpful to moisten the vaginal area, but it also can allow the clitoris to be more sensitive with estrogen cream, so that it's a possibility that could also help desire.
I also find, if I can jump in, that this may or may not be applicable, but many times people that I've talked to who have had a loss of libido, there's usually something else attached to it from an emotional perspective, like either sex has become painful or uncomfortable or not as pleasurable as it used to be, and so they start to retreat from that, and then when there is another person expressing interest, it kind of becomes this vicious cycle of negative emotional reactions. And so sometimes the body mapping exercise that we referenced, and you can read more about in that MS in Women brochure, is a good place to start, because part of it is you and your partner agreeing not to have intercourse for a little while. And there's also something called sensate focus that you can Google, sensate focus, where you are really focusing on rebuilding that intimacy through light touches over time, and then only moving forward when both partners are ready to move forward. And so that can kind of rebuild trust and rebuild some of the energy and emotion behind sex that other things have taken when they have taken it away.
Great, thanks, Megan. So to stay along that line, one of our participants writes about anxiety, specifically at the start of the physical activity. So can you provide any tips or suggestions how to overcome anxiety when you are at the beginning of a sexual experience?
Yeah, I think first it's sort of understanding where the anxiety is coming from, and sort of is that because you are worried about something that's going to happen, that you're going to be in pain. There's a lot of things that I would be asking about where that anxiety is coming from. But if it's more of that cycle that I was just referencing, where sex became unpleasant for whatever reason, and now it's associated with a negative experience, again, something like body mapping or sensate focus is a good place to start because it doesn't commit you to having intercourse. It's kind of working yourself back up to intercourse and only having intercourse when you feel really interested and ready. And so that might be a good place to start in terms of anxiety. But otherwise, I would also say deep breathing exercises, maybe setting up the environment to be very relaxing, trying some like headspace or mindfulness type things before sex just to calm your body's reaction down. Those might all be suggestions as well. Kathy, I don't know if you have other thoughts.
Yeah, it seems like many women are most anxious about incontinence a lot of times during sexual activity. And sometimes that fear is overblown when you check the response from the partner who really is not that much concerned about it. Again, if it would be something like that, sex is messy, sex is wet. And that's what I tell patients. It seems like they do bring that up quite often, that is an anxiety for them.
Great. Let's see what we have here. So this is a common problem for a lot of people that have newborns and finding time for sexual intercourse. And what would you suggest for new families?
Yeah, so I think, so one of the things I would say is thinking about making sure that it's a priority. And so there's a sense that I talk to a lot of people that it has to be spontaneous and it has to be something that, you know, when you feel it, you go. But if you think about when you first met your partner, a lot of us started off with kind of scheduled sex, if you will, because you would go on a date on a specific night. And so there would be anticipation building up to that. And there was a specific time and place. And so it wasn't always, you know, so spontaneous. So I think if you can think about your routine and actually schedule it in, then that might work. Again, I mean, infants are infants, and so that routine might get turned on its head. But I think sometimes it's paying attention to your fatigue levels, recognizing when you have the most energy, scheduling it, and then having some flexibility and humor when that schedule gets messed up, and just communicating. If you're not into it because you're so exhausted and the baby kept you up all night, then talk about it and reschedule the time. So it's really about, you know, communication with your partner and figuring out what works for you. It's a little different for every person.
Great. Kathy, we talked in the beginning of the webinar about the importance of talking to your healthcare team. How do you overcome the trepidation of discussing sexual issues with your healthcare provider?
It's difficult. I mean, I just tell my patients that it is a part of health. It's a part of health. It's a part of our quality of life. And you may have to bring it up. If you do, I think it's an icebreaker in some ways. So I think the provider will then begin to speak about it. But it kind of puts you on an even field almost. So there are some clinics that actually have intake forms where you can even write it down, like I have some sexual dysfunction or ED. So that can be helpful too. I can usually tell when a patient comes into the clinic that wants to talk about it too. And I'll usually say, now, is there anything else that you want to talk about? And then many times it will come up. But with some providers, you may need to say that if you don't feel comfortable with a provider in talking about sex and sexual health, then I would find another provider or someone that you can talk to about it.
Great. Anything you want to add, Megan? This is going to be our last chance to add any tips to our participants, because we are going to have to conclude in a minute or so.
Okay, yeah. So, I mean, sometimes it's just diving in and kind of feeling the fear and doing it anyway, if I have to quote something famous. I think it's giving yourself that mental pep talk, talking to yourself, understanding where your fears are coming from. And then I echo Kathy's comment that if you don't feel comfortable with your provider, or your provider blows you off, or they're not comfortable talking to you about it, I would either find a new provider or find a specialist that you can talk to about this. And again, there's lots of specialists out there: pelvic floor physical therapist, urologist. There's sex-specific counselors. Most psychologists deal with this regularly and talk about it openly. So, you know, if you don't feel comfortable talking with your primary care or your neurologist, see if you can schedule an appointment with any of those types of providers who really feel comfortable and know this topic well.
Thanks, Megan. You know, Kathy, I do want to ask one more question. We did get a couple of questions about pain when having sex. So the question is, any suggestions for vulva pain?
There are some, like there's something called a hyperesthesia in multiple sclerosis. So that's not the opposite of lack of sensation. So some of this seizure medications sometimes can be helpful for that. Or neuropathic pain relievers have been tried.
I will mention that this came up when I was talking to our pelvic floor therapist as well, and she mentioned that there are different tools that they use that kind of help people, especially if they have spasticity. And maybe Kathy, you can speak to this more than I can, but that there are specific tools that they can use to kind of open up the vagina. Is that?
Yeah, a pelvic floor therapist, definitely a physical therapist can do that. It really depends on what the pain is. Like in a clinic, I would want to know exactly what the character of the pain is, where it's at, what it feels like when you have it, to really determine how to get at that. And then a good provider will work it through with you, because that's important. And in fact, you know, you don't want to discount pain either, because it could be something else. So pain is always something that needs to be brought up, regardless of where it's at.
Fantastic. Megan and Kathy, thank you so much for some invaluable information. I think it's something that's very important to all of us. So thank you for your candid and very informative discussion. So with that, we're going to conclude our webinar with some information. Now remember, Can Do MS is on social media. So connect with us on Twitter, Facebook, and Instagram. And I also want to bring to your attention some resources that are available through the National MS Society. They have a variety of brochures and video segments that can be accessed on their website, nationalmssociety.org. But most importantly, you can also contact an MS Navigator. It's a great resource. You can contact them at 1-800-344-4867. Our 2000 Jumpstart programs, as I mentioned earlier, are now virtual. They're personalized jumpstarts. They include 2 learning segments with self-guided courses and a live online program. The live online program includes group discussions and a Q&A session with MS experts. I encourage you to register today and attend this popular program. I would also encourage you to, if you want to do some online learning, we have a part on our website. We have Can Do On Demand. It offers advice from MS experts, and they present on a variety of topics. So I'd encourage you to take a look at our website, and it's Can Do On Demand. Looking forward, we were just talking about pain. The next topic in our webinar series is pain management. It's going to be on Tuesday, September 8th at the same time. So I encourage you to continue to join us for our webinar series. With that, we do have some sources that we cited throughout the presentation that will be available in the presentation that you download and or access in the email, the follow-up email that is sent. So I want to thank again Kathy and Megan for participating with us tonight. But most importantly, I want to thank all of you out there for joining us this evening. We love that you join us month after month for the webinar series. And so please continue to be a part of Can Do MS. I want to say thank you and have a wonderful evening. Good night.
Right.